What is the treatment for listeria causing meningitis? Is ampicillin has to be given for 21 days. Okay. Some people are asking for holiday before the class starts. We'll give you, will arrange. See, our aim is to not keep you idle in the lockdown period. I do understand you need to take out time to study. But if you're devoting at least 2 hours with us to study, that is at least equivalent to 6 hours of your self-reading, I believe. Okay. So don't think this lockdown as a burden on you that we are just putting in a lot of classes. Think it as a peaceful time to study and as an incubation period for a PG seat that you're going to get later. Okay. We'll give you breaks. Don't worry. Okay. So how's your life going on? I think so. You all must be busy at your home, and some people have just logged in. And when you come for the class before time, it's a very rare moment. Okay. 6 hours per day is not at a stretch, my dear friend. Don't count the number of hours. You're always getting a break between next session and this one. Okay. See, some people are really worried and they think that studying that much is going to harm you. Oh my God. And this is not a coronavirus uh, infection that we are giving you. Okay. So no harm, no one dies of studying. Okay. HSV encephalitis is something that is neck rigidity is unlikely to be seen. Like it's an encephalitis. Whenever the brain inflammation happens, it's not the meningeal inflammation all the time. So neck rigidity may not be seen. Okay. Topic for the day today is aphasia with a very interesting topic. Elderly means above 55, above 50. If you go with Harrison, it's above 60 years. Okay. Somewhere I found Harrison is a very typical book to define all the age groups. 12 to 18, they put it as adolescent. 18 to 35, they put it as younger adults. And then 36 to 60 years, they take it as older adults. And above 60 years, anyone is elderly. Okay. Yeah, at the end of the CNS series, you'll always get a TND or maybe a test paper from my end. I'm just trying to prepare it on daily basis. Okay. Okay. One genuine doubt. EEG of the HSV encephalitis. Okay. Right. Yesterday we were in the CJD and we told it's a triphasic wave that we find. Correct. In HSV encephalitis, there is a periodic lateral form epileptiform discharges, sorry, which is known as PLED. Need not go into that much of details because EEG is really a stuff of not your kind, as I told you yesterday. So I'll suggest you to not go into too much of detail of this. Just remember the word PLED over there as a EEG finding found in HSV encephalitis. If I get time today, don't worry. If I get time today, I'll do cryptococcal meningitis. Okay. Because somewhere after our session ends, there is a biochem TND also being left out. So we have to just synchronize. I might end up just on time today. That's a good news for you. Okay. And some of the students are also asking me on the Facebook club, so will you teach channelopathies? There are two periodic paralysis. One is hypo and hyperkalemic. If I get time today or in the subsequent days, pakka I'll do. Promise. Okay. Please inform a week before the test. If I end the classes of neuro on 30th of this month, okay, the class test will come on the 1st of the next month, right? 1st of May. Take it as 1st of May as a class test day for you. Okay. Okay, Midas score was a scoring system that we use for migraine patient. And what is a full form of Midas? I'll tell you again if I Yes, I'll get time, I'll tell you again. Uh, in LEMS, do you get a jitter on SFEMG? No, no, no. Jitter is something seen in a myasthenic patient, not for the LEMS people. Okay. No, whole CNS won't be covered. I'm not a Bahubali who can do everything in this online classes. See, if the lockdown opens as early as possible, we'll start with your live classes. So I think so in the live classes when I see you again or in the VSAT session, I may not be taking these topics. It will just save time for me because most of the students had a lot of query that please do stroke, CVA. It's very difficult. I'll tell you one thing. The question which is asked in stroke is quite different from the content in the textbook. So there is a lot of disparity between the two things. And teaching stroke is not an easy thing. I need to start from the very scratch, anatomy, physiology, and then neurology will come in. So that will keep it aside for the live classroom. Okay. See, congenital myasthenic syndromes are not a thing that you need to be worried about. Just remember a fact that there is a epsilon subunit. If you remember, the acetylcholine receptor had 5 subunits, 2 alpha, 1 beta, 1 epsilon, and delta also, gamma. So there is one epsilon unit which is somewhere defective in them. Okay. Yeah, EG in HSV encephalitis is pled. I'll teach cryptococcal meningitis. I remember. Okay. Suggestion for the pre-final year, my suggestion would be that read the notes once and solve the DQB so that in the final year you got a lot of time to revise all these things. Okay. Okay, FHM is another topic which is a topic which I think so is more theoretical than practical. I'll again explain that. Okay. See what I'm planning in the lockdown period if I'm getting a time or a slot till the 30th of this month. Today I'll do aphasia, tomorrow I can take up multiple sclerosis, a demanaging disorder, and then I can put a very interesting and important topic that is movement disorder and Parkinsonism. Okay. When will you get MCQ you're explaining in the class? Follow me on the Facebook. In every post or rather a meme or a hilarious post every day which I put in, I always put a JPG file of the questions that I have shown in the class. You can just see them once. Okay. Is a problem or issue with the voice today? I think so. My voice is fine. See, no one is very sure when the lockdown will really open up. Let it open up first and then we'll decide how to synchronize your live lectures. So don't be under the impression that you will start you preparing with us in the live classroom lectures and then you'll finish it on time. It will be very difficult. Okay. So let's be practical on this. First of all, we are a human being, and you guys somewhere are imagining yourself as a student of a Karan Johar movie, that everything is so well sophisticated for you, and these things are going to fall in place. We are in a war zone. We are in a situation when there are a lot of limitations on movement, especially in gatherings. So don't live in a dreamy world of Karan Johar movie. Come to reality. Okay. How many questions from CNS? You require a Pandit or a Joshi for that. But this year we got at least in NEET PG 7 or 8 questions. Okay. Yeah, we as you as a student always are maintaining a social distance from your textbooks. I know that. Social distancing maneuver you know very well from your textbook. You know, I still remember in my college first MBBS, there was a great book known as Gray's Anatomy. You must have seen that. And I used to find it always locked in a cupboard with a big lock over there. And one of my college professor in anatomy used to tell me that why are you locking in the cupboard? Do you think anyone is going to steal away the Gray's Anatomy from the dissection hall? Leave the Grays out on the table. People will move 4 feet away from the Gray's Anatomy book. Okay, right? So, social distancing, a maneuver that students usually perform is from their textbooks. Yes, I know that you're very good in that. Okay, time is up. Okay, we are right on time. Okay. When I come for the class before time, oh, बहुत ही rare moment of my life, like Zakir bhai told us once. Okay. So today we are going to deal with another interesting and important clinical topic known as aphasia. But it's a Monday today, and happy Monday to all of you. But someone in the hospital wishes me happy Monday. The Sardar Khan inside me comes out, and I go beating that person. Okay, how dare you wish me a Monday? Right. Now let's begin the class with a very interesting and easy topic that we know as aphasia. If you know, this aphasia is something which is considered to be a disorder in which the person either cannot understand or the patient cannot put out the word that he is speaking out. So there are two things. One is understanding and the other one is a speaking thing. If you know, the word understanding is the meaning is that I am able to understand something which has been told to me, my comprehension. When I'm speaking out to someone, the word is forming in the brain. That is a component of word formation. Okay. So remember this way, there is always two speech areas with us. Okay. When I look into the brain, there are basically two speech areas with me in the brain. One area counts for understanding anything which has been told to me, comprehension. And the second area is for word formation in the brain. Now, if you know these areas, it's very good. For understanding anything which has been told to me, that is the comprehension part, I require an area which I know as the Wernicke's area. Correct? But for forming a word in the brain always, people are asking me cryptococcal meningitis. Stop typing that word. I'll deal it. Don't worry. I'm not running anywhere. Okay? Word formation, Broca's area. So there is a thing which I understand through the Wernicke's area, that is pick it as a stimulation, comprehension. Then I pick out a word, make out a word in my brain in the Broca's area. Now, very important thing, where are these areas actually located in? If I look at the Wernicke's and if I look at the Broca's area, where are they located in? The Wernicke's area is actually located in the superior temporal gyrus. Okay. Broca's area, whenever I look at, is located in the inferior frontal gyrus. So inferior frontal gyrus in the brain, correct, is an area where the Broca's area is being located in, and Wernicke's area is somewhere located in the superior temporal gyrus. Now, if you know the basic anatomy, let me make it in a very schematic and a very simple diagram. If I look at the structure which is known as the brain, maybe in a lateral view, I'm looking at the brain in the lateral view. There is an area somewhere located over here. If I look this as an interior part and that one as a posterior part on the other side, in the interior part, we have the Broca's area with us, which is well located in the inferior frontal gyrus. IFG stands for the inferior frontal gyrus. There's another area with me, which is for comprehension, which I know as the Wernicke's area. And Wernicke's area is somewhere located in the superior temporal gyrus. Right? Please remember this. There is something which is joining the two every time. That means whenever the signal has to come out from Wernicke's has to go to Broca's, I got certain fibers which are coming from temporal lobe to the frontal lobe. Now, if you can tell me the name of these fibers, I will be really very happy. Someone is imagining this as embryo. Good imagination, but that's a brain actually. Yeah, it's known as the arcuate fibers. The arcuate fibers which I know. So there are fibers known as the arcuate fibers which are connecting the Wernicke's with the Broca's area anteriorly. Correct? Now, where is the Wernicke's area going to get an impulse or a stimulation? Like I'm talking to you, correct? The impulse which is coming is in the brain in which area? Auditory. I'm writing this thing in front of you. Now the impulse which is coming into your brain is in the visual area. Now if you remember, the visual area and the auditory area. So there are two areas with me. One area is a visual area which is located in the occipital lobe, if you remember. Another area is an auditory area which is located in the temporal lobe for me. Correct? Now both these areas, remember, are going to give a signal to the Wernicke's area. So I'm putting an arrow like this. So I remember whenever I get an input in the Wernicke's area, it comes from the visual cortex or the auditory cortex. The input is coming into the Wernicke's zone, passing through the arcuate fibers, and now the Broca's area will form the word, and then the speech output will come in. So look at this. For the speech, the input which is coming in is coming from the auditory or the visual cortex. The understanding part happens in the Wernicke's area. The word formation happens in the Broca's area, and then I speak out the speech coming out. Okay? Right? Simple. Now I'll put this in a different way, not like this as a diagram. I'll put it in a different flowchart manner. Okay? I get the input in the auditory area. I get the input in the visual area. I send both the inputs together into a Wernicke's area, and then we reach the Broca's area, from where finally my speech output is going to happen. Okay, let me rewind all this thing. The auditory area was located in the temporal lobe. The T stands for temporal now. Okay, visual cortex, you know, it's a very simple guess. It is located in the occipital lobe. Oh, occipital. Now Wernicke's, if you remember, was a superior temporal gyrus. The Broca's was the inferior frontal gyrus. Between the two is a connecting link that we have is the arcuate fibers, AF, arcuate fibers. Simple. People who have joined in have not missed too much. Don't panic. We are still on the first page. We are discussing a topic known as speech language disorder aphasia, and I'm not doing anything new for you. You already know these concepts from basics, that there is a speech circuit which flows like this. Okay. Now, what do I assess a patient on? Remember this. I can assess a patient on 4 parameters. Okay. In a patient with aphasia, there are 4 parameters that we assess a patient on. For example, I'll take this one first, known as the comprehension. As the word comprehension means, what do I mean by it? As I was talking to you about this, it means ability to follow a particular conversation, right? ability to follow a particular conversation. I'm talking to you, you're listening to me in the auditory area. Now look at this. For comprehension, which area do you require first? I'm talking to you, a conversation is going on. The input will come where? A, the auditory area. Then the input will go where? The Wernicke's area, W. Please tell me, for ability to follow a conversation, correct? Do you require a Broca's area or no? For example, I'll give you an example. I'll ask my patient a simple task. A simple task. Show me your tongue. Raise your hand. Patient will listen to me in the auditory, will understand in the Wernicke's. But like following a task which I give him, does it require a Broca's area? No, very good. You all guys are attentive today. So you don't actually require a Broca's area for this comprehension part. Because for example, I'll give you an example. I'll ask my patient, show me where is illumination in the room. Okay. Show me where is the illumination in the room. Illumination, sorry. So patient will just point his finger up. Yeah, there's a bulb over there, but he cannot speak. Yeah, he can understand my task and tell me where is it. Okay. So this is something a word as comprehension, which comes from the Wernicke's area, doesn't require a Broca's area for it. Right. Second thing that we'll always look into a patient. Can the patient name a particular thing which I have shown him to know? Okay. Right. Let me show this to you if you can see me well on the screen. What object is it? The e-Medico is running with your chat box. Look at this vertical nystagmus you'll have. Tell me what object is this? Answer me. This is a mobile phone, correct? I'll show you again. Is it an iPhone? Is it an iPhone? You'll say no, sir. Why? Because the iPhone has got a round dot at the distal end. That's pathognomic for iPhone, correct? But the new models of the iPhone also looks like this One Plus. But it's not the new models of iPhone. Reason? Both my kidneys are with me. The day I'll sell them, I'll buy one of the iPhones, right? So look at this. In naming purpose, you are being shown an object, right? What will happen? You will see this object where? In the visual cortex. So there is a visual cortex with me where I receive the input on seeing a particular object. I'll send this input into a Wernicke's area. I'll send this input into a Wernicke's area where I'll understand what object is it. Is it an iPhone or a OnePlus model that you have? Okay. Now from the Wernicke's, the signal will go to the Broca's area. So look at this now. You saw an object in the visual cortex. You understood the object in the Wernicke's. You made the name of the object in the Broca's. And then you spoke out what object have you seen. Between the Wernicke's and the Broca's, which area or which part is functioning? The arcuate fibers again. So now find this out. For naming or seeing a particular object and naming it, the input comes from the visual cortex, goes to the Wernicke's, goes to the Broca's. Simple. Now there are naming deficits. Remember this. Patient has got deficit in naming. It could be in various types. One type of naming deficit which the book tells me is one way or retrieval based naming deficit, in which the patient cannot name an object but can point towards the object. Look at this. This is known as a retrieval base. I'm trying to retrieve it from him. I'll ask him, what is this object? He doesn't name it. Suddenly I ask him, tell me where is a mobile phone? He cannot name a particular object properly, cannot name it. See, this is some object. Then okay, fine. Then I ask him, where is the mobile phone being kept? He might just point it, like where is the bulb, illumination in the room? He'll tell me that. But when I show him the bulb, it's very difficult for him. So he might just point out the right object, but he cannot name it properly. See, he just says like this. I'll give you another example. He looks at this object and tells me that this is an object for maybe listing something. Okay, that's it. And then I ask him a leading question, where is a mobile phone being kept? He just looks at it and tells me, yeah, this is the one that you're asking me. So he might point towards the object well, but onto the other end, when I ask him the real name of the object, it's very difficult for him to retrieve out. Okay. Now another one is a two-way naming deficit. Two-way deficit is also known as the semantic deficit. In which one thing happens to some extent, patient cannot name, cannot point out also. So remember this patient of two-way naming deficit, I show him a mobile phone, he cannot tell me it's a mobile phone. I tell him, okay, fine, where is a mobile phone being kept? Tell me in among all the objects that are there. He cannot tell me that also. Okay, one-way and two-way naming deficit. These are the simple things. Now, there's another thing that we all should know about as a naming deficits that we have in the patient is known as paraphasia. Now, what is paraphasia? I can just give you a simple example to explain what is a paraphasic error. It can be of two types. It can be a semantic or it could be a phonemic kind of paraphasia that we have. Right? Now what happens? I show a pencil to the patient. Now let us be on this example. Right? I show a pencil to the patient and he tells me it's pen. This is known as semantic paraphasia. Okay. In phonemic paraphasia, I show a pencil to the patient and he tells me it's a pentel. Now find this thing out. It's very easy if you try to catch this topic. He knows in semantic paraphasia the function of the object, okay? And he tells me a related word to it. I'll show him a pencil, he will look at it and he knows for writing and he tell me it's a pen, some related word. That means in semantic paraphasia, patient tells some related word of the object. Like it's an object for writing. He looks at a pencil and then tells me a pen. He tells me some related word related to it. Okay. Now pencil becomes pentel. Now what is this? This is something which is known as phonetically incorrect. It's phonetically incorrect kind of a statement. That means a patient pronounces the word in an improper way. Instead of pencil, he tells me it's a pentel. So this has been a question in 2018 NEET PG. I still remember this question, that a patient has been shown a pencil and he names it as pentel. It's a spelling error with him. Okay. Now there's another concept that you all should know about is circumlocution. Circumlocution. Now what is circumlocution? Correct. You know what happens in circumlocution? The patient tells the examiner actually function of the object shown, okay, without giving the right name of the object. I'll repeat, don't worry, don't panic. Okay, I'll repeat everything. Patient tells the examiner the function of the object without giving the right name. For example, I'll show him a pen. He will just keep on telling me, yeah, I also have it. I keep it in my pocket, the same object that you are showing me. What is the name of it? I don't know. It's useful for writing somewhere. Look at this now. What is this thing? Beating around the bush. Like, I'll give you an example. I went for a Viva. I remember in final year MBBS here, medicine Viva, and the examiner on the other end, who asked me a very typical question. I was roll number 1 in my college, as I told you. The only question that every year asked me, what topics have you read? Okay. But after that, he asked me a very simple medicine question. Tell me, doctor, what all anti-epileptics can cause seizure? Now look at the question. What all anti-epileptics can cause seizure? I just looked at this question and heard it, and I had myself absent seizure because I did not know the answer. I said, okay, fine, sir, I'll still answer because I'm roll number 1, full of ideas, thoughts. I said, sir, there are various anti-epileptic drugs and various kinds of seizure disorder that I have. But some anti-epileptic drugs have been known to decrease the GABAergic activity in the brain, which is inhibitory. And that might increase the glutamagic activity in the brain, that is excitatory. So all those anti-epileptics can cause seizure. Great. Sir, listen to my speech. After 1 minute, he asked me one question. What are those drugs? Yes, doctor. Okay. So that's a practicing thing in a Viva, OC, that you always do, beating around the bush rather than telling the right answer. It's known as circumlocution, right? So I'll repeat everything again in a very fast go. Naming deficit are in 2 parts. One-way retrieval based or a two-way semantic deficit. In a retrieval based, patient cannot name an object but can point towards the right object if I am asking him. Two-way semantic deficit cannot name, cannot point out either, right? Paraphasic means a problem not in a sense that he cannot name properly. There is some calculation error. The patient looks at the pencil and names it as pen, tells me the related word, or maybe phonetically incorrect statement, that is pentel, right? Then we have circumlocution. That's the best example I could ever, beating around the bush, right? What's the answer for the question? Okay, you tell me. What all anti-epileptic drugs are not given in a patient of JME? The answer was from this. What all anti-epileptic drugs are not useful in a patient of JME, or rather contraindicated? What all? Yes, carbazepine and phenytoin. Your long-term memory will help you today. Short-term, sorry. So there were 2 anti-epileptics contraindicated in JME because they exacerbated myoclonus. In the very first class we have read this concept. Okay. So very catchy question. Now after the naming thing, as you know, we'll move into the repetition part. The repetition part. Okay. Now, what is a repetition part? That means the patient is able to repeat with me what I am telling him. As the word suggests, repetition. Correct? For example, I'll give him simple words like no, ifs and buts, 1, 2 and 3, whatever. As you can make a speech circuit for repetition is very simple. Whenever I speak a word to the patient, the input comes in the auditory area. Correct? From the auditory area, the input will go into the Wernicke's area. From the Wernicke's area, the output will come out to the Broca's area, and then the speech output would come out for me. So for repetition, look at this again. The input is now coming out through the auditory, going to the Wernicke's, placing itself into the Broca's, and then the speech output is going out. That is a concept of repetition that we have, right? It's very simple. So you might just give him a simple word, or maybe a complex word like hippopotamus. Can the patient repeat this word with me or not? Or maybe he can give this word to him. Trivantapuram. I hope any Kerala student is there with me, can tell me the right spelling of Trivanthapuram. I still don't know, because there was a student in classroom and the teacher asked, where were you born? He said, I was born in Trivanthapuram. Then the teacher asked him, tell me the spelling of Trivanthapuram. Then immediately the boy said, no ma'am, I was born in Goa. Must be a medical college student, pakka. Okay, smart people. Oh, it's not TH, it's TIRU. THR. Please, all the Malus in the batch, sorry. Okay, poor in that. All right. Now, another concept is the fluency part. Now, how do you look for the fluency thing? Remember this. I'm speaking anything which is coming into my mind. So, a lot of Malayalis in the batch. Okay, good. God's own country. Possibly after Goa, we'll get free from Corona. Good, great work. Now, fluency. Now, fluency is something that we assess out as a spontaneous speech. For example, whatever I'm talking, am I talking properly or not? So, I'm talking when I'm forming the word in the brain. So, can you tell me for fluency? That means a proper speech which is totally fluent. Okay, the word formation happens, and this word formation happens in which area of the brain? The Broca's area. So don't forget this thing, that the Broca's area in the brain is for word formation, and that is going to maintain the speech output that we know as the fluency part. Correct? Now, if you know this concept, a speech that is normal, okay, I can put like this: a spontaneous speech when I'm talking to anyone, a spontaneous speech whenever I'm talking to anyone require the Broca's area for it, word formation thing, right? Now, in the spontaneous speech, it can be in two parts. Either it could be a fluent speech, or it could be a non-fluent speech. A fluent or a non-fluent speech that we have with us. Okay? Now, what is the meaning of the word fluent speech? What are the characteristics of a fluent speech that we look at? First thing, the output volume which I am thinking about. The amount of words which I am putting out in my speech, or the output volume. The phrase length. The phrase length, what I am talking about as a sentence. Am I completing my complete sentence, or am I halting in between? Okay. So the output volume, the amount of words that I am putting in, and the phrase length, that is a word output that I am giving in a single phrase. Is it okay or not? And then don't forget is a very important component known as melody. As the word goes as fluency, the word melody is again important. The melody as a word comes in ability to what? If you know this, ability to sing something. Ability to sing something is defined always as a word melody. Okay, that is constituent of melody of speech, ability to sing something. Now, if at all, the speech is non-fluent, what are the problems with me? If you can understand this, the words which I talk are very far apart. The sparse words are there. There's a lot of break in the words which I'm putting out. In fact, the output that I have is often halting. That is, I'm not putting out the words, I'm intermittently stopping in between. And the average word output that I give out is 4 or less than 4 words, right? So what we find is melody is a component of speech output, again ability to sing something properly or not. And if the speech is non-fluent, then average word output is less than 4 words. Now this is something important we'll discuss later on. Okay, yeah, people are putting their own words here. Melody is very chocolatey, I know that, right? Stammering is something different. Okay, stammering, I'll come to the word stammering also. Okay, so no genuine doubt till now. All faltu doubts are there. Now do one thing. I'll just get some pages with me. I got some papers or not. Okay, right. When you're writing in your notebook most of the time, you somewhere write it on the length most of the time. You start here and you end here, right? But this time I'll suggest you to do one thing. Okay, look at the screen, please. Write along the breadth in the landscape mode, right? And if possible, some notes with me today. I'll just show the paper. Right. If possible, make 2 pages as one, right? So write along the breadth, right? Make 2 pages as 1 page in your notebook or the register that you are carrying. That means you're going to start on this part and you're going to end here, okay, in the landscape mode. Okay. Whatever people have not been able to understand, don't worry, don't panic. When we are going to discuss everything in actual disorders, you're going to come back to that concept again and again. I'm going to ask you guys now. It's a very simple topic of aphasia. Don't worry. Be happy. Right. Some emesis fugax just happened. Don't panic. All is well. Okay. Don't type black screen, black screen. I know. Do one thing. Right, as I told you, and on the top, right over here, auditory. On the top of the page that you're writing on, right here, auditory. Here you put the word as visual. It will all go into a zone to understand anything that I've been told with. Wernicke's. Going out to the area for word production, that is Broca's, and then finally a speech output would come out. Okay, so right along the landscape mode, as I told you, in the registers that you are carrying, and some people I know are carrying the photocopy notes also, so carry on. Now I'll come back to this again. There are few components of speech that we have with us. There are few components of speech that we have with us on which we are going to assess a patient with aphasia, right? I'll repeat naming again. Don't panic. I'm not going anywhere. I'm still on this topic. Okay. Draw one thing. I'll make a table with 5 vertical columns. From left to right, we'll make it as 5 vertical columns now. So they're going to be 5 vertical columns with us, and we make it a table like this. And now what we'll do, we'll try to see every kind of a speech or a language disorder based on the 4 variables that I told you, right? Then the first word that we have is aphasia. Now on the left side, you can write aphasia as a word. Okay. Then comprehension. Okay. Then we have the naming word. Then we have the repetition coming in. And the last word that we have with us is the fluency part. Okay. So these are the 4 variables that I was talking about in which we are going to assess any patient with a speech or a language disorder. Now I'll ask you, what do you understand by the word comprehension? For example, I'll ask my patient where is the illumination in the room. He will point me that. That is known as the comprehension part. Correct? Whenever asking him to answer my conversation or anything, or to follow the command which I'm telling him, which area worked for it? So I'll just put few abbreviations for them. C for comprehension, N for naming, R for repetition, and the last F part is for fluency part, right? So what we'll do for comprehension, what we'll do for comprehension, whenever I speak to him, the input will come in through the auditory area. So for comprehension, again I speak, I tell him a command to follow, the input comes in the auditory area, right? Now for comprehension, which area do you require apart from auditory? You require the Wernicke's area for it. Now, if you know this again, do you require Broca's area for comprehension? A big no, no, no. Then comes in a naming thing, naming. For example, I'll just put the word naming again. I'll show an object to the patient. He will look at the object in the visual cortex. He'll understand the object which I have shown him in the Wernicke's area. He will make the name of the object in the Broca's area and will very politely tell me what object has he seen. So naming requires the visual entry, the Wernicke's and the Broca's. I just forgot to tell you again, the bridge between the Wernicke's was arcuate fibers. Then comes in the repetition. Okay. Then comes in the repetition thing. Whenever I tell him to repeat anything which I am telling him, I speak out a word and the word comes in the auditory area. Okay, I speak out a word and the word comes in the auditory area. Correct? After this, the word goes into the Wernicke's area for understanding whatever I have told him. And finally, the word which I am using or I am telling him to repeat comes out from the Broca's area. So it's a very simple thing. We are just revising what we have been told. Okay. Now the doubt comes in. So naming also requires auditory. No, as such. I'll come to your doubt in a separate way. When I'm going into the aphasic patients, I'll tell you again about this concept. Okay. Some people is writing it's very fast, too fast today. No, no, no. I'm not fast. Actually, I'm very slow today. You are too slow. You're slower than me. Okay. So I don't think so. I'm very fast. I'm repeating everything which I'm telling you again and again. Then we have the fluency thing. The word formation. When I'm forming a word in the brain, it comes in the Broca's area. It forms in the Broca's area. So fluency of the speech is something that is from the Broca's area. So look at this now. Fluency is something that is from the Broca's area, the word formation. Repetition is something that comes in the auditory area, goes into the Wernicke's, goes into the Broca's. Naming is something the input comes in the visual, comes into the Wernicke's, goes into the Broca's. And for comprehension, I just come into the auditory and then into the Wernicke's. Okay. I've repeated it also so many times. Now, not only I'm going to talk, you guys are also going to type me few things. So be with me, be on this space, pay attention. I know your attention span is very poor, especially on the online classes. Lot of distraction. Try to remove all the distraction and just be with me for next at least 10 or 15 minutes. Okay. Now I'll ask you this question. If there is a patient of Wernicke's aphasia, if there's a patient with Wernicke's aphasia, what will happen to the comprehension of the patient? Can the patient understand me what I am telling him? Yes or no? Yes or no? A big no. Comprehension is lost because the Wernicke's area is lost, and the Wernicke's aphasia is an aphasia due to damage in the Wernicke's area. It's very simple. Now comes in the naming part. Naming. Okay. Can you tell me now, can Wernicke's aphasic patient name an object which has been shown to him? Look at this now. If the Wernicke's is lost, can he understand the object that he has seen? No. So naming is also gone with the patient. What about repetition? What about repetition? Again, it's lost. But what about fluency? What about fluency? What about fluency? It is maintained to some extent. Yes, normal. Because for fluency of the speech, I require Broca's, and the Broca's area is working well in this patient. It's normal. Fluency is normal in them. It might increase also. It might increase also. It might increase also. Because patient doesn't understand what he is speaking. Look at this now. I am understanding what I am speaking. If I don't understand what I am speaking, I'll just keep on talking. That is, at the end now, right here, The speech of the patient is often found to be very explosive. Too much of words are coming out in the output. And this kind of a speech is also known as a jargon speech. Jargon. There are a lot of jargons of words which are coming out in his speech, all not connected well to each other. And remember this thing, patients of one case, when they don't understand what they are talking, they might just give out some words which actually carry no meaning. This is known as the word neologism. Neologism. Got my word? Neologism. A new word which carries no meaning. Now, for example, if you have watched this great Bollywood blockbuster, Three Idiots, it made a sense, that movie. Rancho got up in the class, if you've seen Amir Khan. He just wrote two words on the blackboard and asked everyone in the class to search a meaning of that two words. It was pre-radialization and Farhan nitrate, if you remember that movie. So he made two words which actually carry no meaning, okay? So this is the blunder they also do. They make certain words which carry no meaning known as the neologism. Okay, yeah, chatbox is a jargon speech. Excellent. Who wrote it? Commendable. Now, please tell me which neuropsychiatric disorder will have neologism as a complaint. Asking this question, which neuropsychiatric disorder will have a neologism complaint? Yes, it's schizophrenia. Schizophrenic patients, if you read in psychiatry somewhere, they often neologate. They make words which carry no meaning. Yes, good. Then we have another aphasia, quite simple to understand. That's my Broca's aphasia. Look at the Broca's now. In the Broca's aphasia, what will happen to the fluency of the speech? First of all, I'll start from the other side, fluency part. Tell me please, what will happen to the fluency of the speech? It is going to decrease because the word formation in the output is going to decrease, one thing. Right. What about repetition part? Can the patient repeat with me what I am telling him? Never, never. Because he cannot form the right word which I am telling him to repeat. Naming. He can see the object, he can understand this is something meant for listening or something, but he cannot generate the right name of the object. That's the problem. Naming is absent because he cannot generate the right name of the object. Comprehension, very simple. If I am asking him where is the illumination in the room, he will show me that. Because for that he doesn't require the Broca's area, he just need to listen and understand me. That means a comprehension in patients of Broca's aphasia is going to be perfectly normal in them. Now find this out. There's a big problem in the Broca's patient's life. In a patient with Broca's aphasia, what do you find? They can understand. Comprehension is intact, but they cannot speak. That means they can understand something and they cannot speak. As the saying goes in Hindi, Ek tha tiger ban gaya barfi. So he cannot speak. Till yesterday he was like a tiger to everyone. Look at this patient now. This patient has got an intact insight into his disease. He understands what's going around him. Now please tell me, yes, good. Some people are answering me beforehand. They will go into depression. Once they understand what's going around them, they cannot talk to anyone. Yes, they go into a phase of depression. Now look at this arrow. I'm very clever in making this Broca's arrow. The arrow is pointing downwards now. It's pointing downwards. That means whenever they talk with a lot of halt in between while speaking. Such a halt that comes in their speech is known as a word telegraphic speech. If you remember, the telegram was a mode of communication long back in which the signal from one end to the other end was sent through the Morse code. So what you have, whenever they speak with a lot of halt in between, telegraphic. For example, you must have heard Shah Rukh Khan, King Khan in most of the movies, romantic blockbusters. How does he talk? Kiran, hey, hey. But whenever he sings out, he becomes totally normal. Because he doesn't sing, Arijit sings for him. That means in this patient, melody of this speech is often preserved or normal. That means When this patient wants to talk, they might integrate the word subconsciously with a string of melody, and they can just come out with a typical speech pattern known as a term melodic speech. Melodic speech. Now I'll give you an example. If you have seen this old Bollywood movie which actually flopped at the box office, Ranbir Kapoor, the Jagga Jasoos. If you've seen that movie, he had a very typical problem. Whenever he was talking to anyone, he could not talk properly or confidently, and someone was telling me stammering. Okay, it might equate to that also. But whatever expressions were there in him, he used to always tell it to everyone with a perfect song. The whole movie went out in a very nice song. See, melody is something which is required for singing. Fluency is something which is required for speaking. See, when I'm speaking, I'm forming the words there and then only. Listen to me. When I'm singing, am I forming the words there and then? No. Those lyrics are there in my brain subconsciously. I could integrate all those lyrics together with a string of melody and come out like a song. Very simple. So at your level, just remember one point. Broca's patient, when they are speaking, they're halting in between a lot, telegraphic. But when they come out to singing, they become totally normal melodic. Another reference, like for example, you heard great Bollywood singers. Most of them are from South. For example, A.R. Rahman. Whenever A.R. Rahman is speaking Hindi, he is often telegraphic. But whenever he is singing, he is perfectly melodic. Okay. Now, another aphasia that we have with us is the conduction aphasia. Conduction aphasia. Now we have the conduction aphasia. Conduction aphasia. Now, as the word conduction comes in, what is the meaning of the word conduction? It means transfer of energy from one point to the other one, and both are connected to each other. That's the physical meaning of the word conduction. Now, look at this. There is a gap between the Wernicke's and the Broca's. The gap is the arcuate fibers, and suddenly this arcuate fiber got broken. Correct? The arcuate fibers suddenly got broken. What will happen? Patient will understand. Now answer me please. Arcuate fibers got broken. What will happen to the comprehension of the speech and fluency of the speech? Or rather, I can ask you this. Naming and repetition. Will it happen or no? Tell me that first. N and R, naming and repetition, will happen or not? If there is a lesion between Wernicke's and Broca's in the arcuate fibers. Obviously no. Because for naming and repetition, you don't require Wernicke's and Broca's. You require arcuate fibers also to transfer the whole concept from Wernicke's to the Broca's. Now this arcuate fibers got broken. It's very simple. If the arcuate fibers got broken, there is no conduction of impulse between Wernicke's and Broca's, and naming and repetition won't happen. Comprehension is maintained. Fluency is normal. And I'll put increase also. Why increase? Because the Broca's of the patient is not connected with the Wernicke's now. So the fluency might increase also. So it's a very simple thing. Now one gentleman is continuously asking me this, that when the patient cannot speak, how can he sing? See, when I'm singing, for example, I'm singing simple lyrics or any song that I know, I don't form the words then and then. You don't require the Broca's here, right? You require subconscious words which are there in your mind. For example, you are just lying down in the bed and singing something. Are you forming the words there? Lyrics? No. Those lyrics are there in the brain somewhere, integrated by a string of melody. That's why you're able to reproduce it as a well song. I've tried this out. You know, in my clinical experience, many very common patients of stroke used to get admitted. And they were aphasic. And they were patients of Broca's aphasia. That means they could not speak to anyone. And on top of it, they were depressed also. Looking at such a patient, the relatives are more depressed than the patient himself. And the relatives never wanted to take the patient home. They said some hospital, some magic will happen or something will happen. Then every time I used to go to that patient and tell him to say a simple Gayatri mantra like Om Bhur Bhava Swa. Now that Gayatri mantra he must have heard earlier, no? So there's lyrics of Gayatri Mantras there subconsciously, and he can integrate this with a string of melody. And whenever I asked the patient to enchant the Gayatri Mantra, he became very normal. Now the credit went to the God again. They said the God is so great that the first word that he's uttered out is a Gayatri Mantra. Why did the patient utter out the Gayatri Mantra? Because his melody of the speech was preserved. He could integrate those words of the Gayatri Mantra, which are there subconsciously with him in the mind, and he could reproduce as a very song. So all the relatives took the patient home. I was happy. They were more happy than me. Okay. Yeah, chamatkar. Fluency is normal. That means a spontaneous word that I am putting out. Whatever word I am putting out spontaneously, that is normal in the patient. Okay. I'll give examples. Don't panic. I'll give examples for everyone. They're very simple examples. Broca's aphasia, right? Broca's aphasia has to speak a simple sentence. I like the sentence. I am a doctor. Okay, nowadays you can proudly tell anyone that you are a doctor because people are really appreciating your work in the COVID pandemic. Don't tell your landlord that you are a doctor. Tell him you are a compounder. They will be happy to keep you inside. Or you may be a chemist maybe. So I am a doctor. That's a simple sentence. A patient with Broca's, whenever he's going to speak the same sentence, is going to speak like this. I am doctor. Right? Simple. There is a lot of gap coming in, a lot of stress in speech which is coming out. Like a typical telegram. If you remember that great Donald Trump, when he came to Ahmedabad to meet his friend, and he was talking the name of our great Saint Swami Vivekananda, I don't know, that funny guy. So that was a typical telegraphic speech, a lot of halt in between. Try to join the words. One a case. How will a patient of 1A case talk to me? His speech output is normal or might increase also. Explosive as a jargon. He might just come like this. I am a very important man. I am very useful for the society. I am doing a great job for the people around me. I am the great doctor. So instead of somewhere understanding what he is speaking, he wants to just convey that I am a doctor. He puts a lot of words in an explosive manner. That's a jargon. Okay. Yeah. Swami Vivekananda, pata nahi what he told, that idiot. But our Prime Minister was very smart. I'll tell you what our Prime Minister did. If a patient comes and tells me and speaks out like this, I am a doctor. Look at this name now. He is speaking to me and he speaks out like this to me. I am a doctor. Can you tell me what speech deficit am I talking about? It's very simple speech deficit. Yes, that is a speech deficit known as a scanning speech. That is, every word he's speaking out, he's trying to scan out. Now someone was asking me, where do you find a scanning speech? So whenever he's speaking a word, he's interrupting. No, he's just reading every word he's speaking about. Scanning speech. Now can you tell me which condition do you come out with a scanning speech? Yeah, that's a cerebellar lesion. I'm just writing for information purpose. In a cerebellar lesion of the brain. Remember this? We get a typical speech pattern which is known as a scanning speech. Right? So our Prime Minister pronounced Donald Trump's name in a scanning speech manner. He was not wrong, he was right. Okay. Right. We'll do one thing. We'll take just a chota sa break at this point. 2 minutes. Some people have been requesting since yesterday to me a lot. So take 2 minutes of break in between so that the synchronization or the audio visual lag should not happen, and the black screen will be slightly lesser. Okay. So we'll just take a 2-minute break. I'll just re-log in again. Right. So have some water, get up from your place. Come back again after 2 minutes. 2 minutes break. You can make a Maggie in this time. How useful time 2 minutes is it? 2 minute Maggie, you know. Okay, I'm back. I'm back. So I just made a nice Maggie in this 2 minutes, which I'll have at the end of the class. 45 seconds are remaining. Oh my God, some people are sitting with a clock. Great people. You should be in the attendance department of the college. You'll give me overtime if I work. I told you 2 minutes. It's fine. I took 2 minutes time. See what happens? It's a theory of relativity, you know. In the classroom, you just think that time is not moving, time is not moving. Okay. Who controls melody? Melody is not controlled by the broadcasting, first of all. Remember this, the broadcast area is not exactly for the melodic speech. You know, melody is just like a string in which I join the words which are there subconsciously be. So look at this. Conscious words are formed in the broadcast, or there may be some areas which is forming and storing words in my brain earlier in a subconscious way. Okay. So what happens is that we find somewhere that the melody is preserved in patients or normal in broadcast. So that broadcast area is meant for speaking out something that is lost. But in these patients, the melody is quite normal and they can reproduce everything in a song. Okay. Why is it a scanning speech in cerebellar? When we'll discuss cerebellar lesions in the classroom, I'll come to that concept. Don't worry. Scanning is not seen in broadcast. Do not write this. It is seen in cerebellar lesions. No. Scanning is something different. I'll pronounce it again. E, a, g, o, t. That is a broadcast. Correct? And then we have a scanning speech in which every word which I'm speaking out, I'm just reading it in the brain. I-A-M-R-D, octar. Okay? Fine. We'll just start again. So we'll make again 3 boxes below this one. We'll write 3 boxes below this one. Yeah, scanning means every word which I am speaking, I may be fluent, but I am putting a stress on every word. I-A-M-R-D, octar, scanning. It's telegraphic. A lot of halt between 2 words. The average utterance rate may be less than 4. It was a telegraphic speech. But the utterance word is more than 4, but I'm putting stress on every word that I'm speaking is a scanning speech. Now 3 more aphasias. These are 3 brothers all together. Okay. Remember the names? Transcortical sensory aphasia that we have with us. Transcortical motor aphasia that we have with us. Some emeresis fugax is happening. Don't panic. All is well. All is well. All is well. Don't panic. And the mixed transcortical. So there is a transcortical sensory, there is a transcortical motor, and a mixed transcortical that we have. There are 3 things. Okay. So let me put few more words onto them. Transcortical sensory is known as the posterior transcortical. This one is known as the anterior transcortical. The anterior transcortical. And this one is known as the isolation aphasia. Isolation aphasia. Okay. So these are few words which are extra attached to them. There are 3 transcortical aphasias with me. The transcortical sensory, which is also known as the posterior transcortical, transcortical motor, which is also known as the anterior transcortical, and the mixed transcortical, that is also known as the isolation aphasia. Isolation aphasia. Okay. TC stands for transcortical. Okay. Now do one thing. Have patience first of all. I'll just tell you a simple trick how to remember all three of them because it's very difficult to understand it in the textbooks. Transcortical sensory, transcortical motor. Now tell me this first of all. Wernicke's and Broca's, who is sensory aphasia? Now tell me that question first. I'm asking you, between W.R. Wernicke's and B.R. Broca's, who is sensory aphasia? Answer me that. Yes, that's the Wernicke's aphasia. Who is motor aphasia? Who cannot talk? Obviously, that's the Broca's aphasia. So please remember this concept. Sensory means cannot understand, that's the Wernicke's. Motor means cannot express, that's the Broca's. Okay, now stop typing. Stop typing. Just remember the simplest trick to remember them. Transcortical sensory is like Wernicke's. Transcortical motor aphasia is like Broca's, with one thing intact in both the brothers, that is repetition. Please write this down. Transcortical sensory is like Wernicke's. Transcortical motor is just like Broca's, with preserved something between the two, that is known as the repetition. Okay. Now please, a question might come into your mind. Why does this thing happen? Leave it. Why is not that important at your level. Don't go into the why. Just remember what happens is more than sufficient. इतने ज्ञान की जरूरत नहीं है. It's very simple. Okay. So repetition is preserved. That's the only thing that you need to remember here. Don't go into the why thing. It's very complex at your level to understand. Leave it. Transcortical sensory, the comprehension is lost. The naming is lost and the fluency is normal or increased, just like the Wernicke's patient. Transcortical motor is like Broca's. Fluency is decreased, naming is lost, and comprehension is preserved like a Broca's patient. So transcortical sensory and transcortical motor. Sensory is like Wernicke's, motor is like Broca's, with preserved repetition in both of them. Correct? Another one. Isolation. That means I mixed the two. Repetition is normal. And what is lost? The naming is lost, the comprehension is lost, and the fluency is lost. Now don't ask me again why sir. Leave that why. Just remember what happens. See, what is common between all the transcortical aphasias is a preserved repetition. Transcortical sensory is like Wernicke's, transcortical motor is like Broca's, and the mixed transcortical is a mixture of the two. That means everything goes negative and the repetition is the only thing that we have positive in the patient, normal. He's so alone, he's isolated. You know, very tricky thing happens in this patient. I'll ask him, what is your name? He'll answer me, what is your name? Then I look at him and ask him, you tell me first. He asks me, you tell me first. Are you mad? Are you mad? So look at the patient now. Whatever I am speaking to him, he is not understanding to answer it properly. But whatever sound or word is coming to him, he's just repeating it to me. My word goes to him and comes back to me. That's a very typical psychiatric term. That is a constant repetition of the words whichever is being told to the patient. Known as what? Echolalia. Echolalia. So constant repetition of the words happen. Whatever the word patient hears, he just repeats the same word without understanding the word. I'll give an example. I was in my residency, I still remember. A patient of a cardiac arrest was there in the ICU who we revived 2 days back. I went to his cubicle and asked him, how are you? He looked at me and answered me, how are you? I said, I am fine. He said, I am fine. That's a normal conversation. Nothing wrong in that. But when the HOD sir came around, he looked at his case sheet and asked me, where is the ECG? Patient looked at me and asked me, where is the ECG? Sir looked at me Patient looked at me. What's happening? Sir looked at me and I said, sir, sorry, sir, I could not get it done. Patient looked at sir and said, sorry, sir, I could not get it done. Sir now looked at me and said, get out. Patient again looked at me and said, get out. So that drama happens in the life. This patient just keeps on repeating every word that he's being heard. He never understands the word. He neither spontaneously speaks to anyone. Whatever is coming, he's just speaking the same thing again and again, known as echolalia. Now, two more brothers. My advice would be, please don't go into too much details of this. इतने ज्ञान की जरूरत नहीं है, but just try to at your level understand what's happening wrong in the patient. Then this one, pure word deafness. Now follow this. This is a very, very important thing. Recently asked topic. And pure word blindness. There are two things that we have with us: pure word deafness, pure word blindness. I'll abbreviate them. PWD stands for the pure word deafness. PWB, it's W. PWB stands for the pure word blindness. Don't forget, the pure word blindness is also known to me by another name known as alexia. Alexia is another name given for the pure word blindness. Okay. Now look at these names. It's very self-explanatory of ASIC patients. One patient is deaf to words. One patient is just blind to words. Okay. Now I'll come back to this. I'll take you back into the speech circuit that we made in the first part, the above part. In pure word deafness, there is no transmission. Please pay attention to this. Very important, easy. There is no transmission impulse between the auditory and the wernicke case area. So there is some breakage between the auditory and the wernicke case area. The transfer impulse doesn't happen here. While with the visual area, the impulse is well connected. So whatever impulse is coming from my visual cortex, I'm connecting it to the wernicke case. But whatever impulse from the auditory is there, I'm not connecting it to the wernicke case. Right? Okay. Now look at this and tell me. It's very simple. If there's a patient with pure word deafness, what would happen with the patient? His comprehension obviously is lost. His repetition is also being lost. Correct? Because the comprehension thing doesn't enter the wernicke case, neither the repetition thing. But what about naming? His naming is preserved. Why? Looking at an object, understanding it. Looking at an object, visual, understanding it, wernicke case. This happens simple. So his input from the visual cortex to the wernicke case area is intact, and he can transfer the impulse very simply like this. Look at this now. What will happen to the fluency part in pure word deafness? Obviously normal, because the word formation happens in the Broca's. In the Broca's area is well connected. It's well normal now. So his fluency is normal, his naming is normal, while his comprehension and repetition is something abnormal. That's a patient with pure word deafness. Let me write this down. Don't worry, don't panic. I'll give you examples at the end. You'll understand it through the examples better. I'll deal with the theory first. Comprehension is lost. The repetition is lost. The naming is normal. And the fluency is intact. Okay. Pure word blindness. Pure word blindness. Comprehension is decreased in the patient. For only one parameter, remember this. Reading. That means my patient cannot read whatever has been shown to him to read. Okay. The patient cannot read a thing, whichever has been shown to him to read. That's the only deficit. So comprehension is decreased for reading only. While he can look at the object and tell me what it is, he can repeat also, he can speak also. Now look at this deficit now. He's just blind to words. The words are written in front of him, he's just blind to it. They're written on a piece of paper. He looks at the piece of paper and he knows it's a paper, but whatever is written on it, he doesn't remember that. He doesn't recall, he cannot read it properly. Okay. I'll give examples, don't panic. For example, this is the mobile phone there on the table, and now the mobile phone vibrates on the table. I know the vibrations are so synchronized, these are the vibrations of the mobile phone, correct? I pick up the mobile phone, I start listening to it, and suddenly on the other end, whatever the other person is telling me, I cannot understand it. My comprehension to a particular word is obviously lost. Look at this now. I can look at the mobile phone and can easily find it on the table. My naming is intact, correct? And on the other end, look at me. I'm listening to the mobile phone, I'm picking it up, everything fine. I listen to it and I cannot understand what the other person is telling me. And I tell the other person also, what happened? What happened? What happened? The other person really got scared. What happened to him now? So I can speak, I can name, but I cannot repeat maybe. Neither can I understand the other person, whatever telling me. I'll give another example. For pure word blindness, I look at the mobile phone now, okay, right? It's ringing. I pick it up. And who's calling me on this mobile phone? It always comes on the dialer mode, right? So I look at this. I just keep on looking at it. What is written on this screen, I cannot read it. But anyhow, I pick up the call. I understand what the other person is telling me. I understand the other person. And then I ask the other person, who are you? Look at me. I cannot read a word which is written in front of me. But the auditory input, whatever for the word is coming to me, I'm able to understand it. My reading is the only thing which is impaired for me. My naming, my understanding to a spoken word is perfectly intact for me. I'm just blind to words, pure word blindness. For example, if in the classroom you are not attentive, whatever I'm speaking, you are not just paying attention to me, you will be deaf to my words, pure word deafness, right? But in the exam, a question comes on a fascia, you will look at the screen, what is written over there, you will not be able to read it even. You will have what? Pure word blindness. Okay? That's why I keep on singing this. बड़ा पछताओगे, बड़ा पछताओगे. क्लास में जब सोते जाओगे तो बड़ा पछताओगे. Okay? So it's a very clear kind of examples I've given for you. See, don't put dyslexia over here. Dyslexia is something, a different story. Okay, I'll not talk about dyslexia at this point. It's something different. See, naming is normal because whatever is, like for example, this is a computer, a laptop in front of me. I'll pick up the laptop, I'll pick up the keyboard, but on the keyboard, whatever words are written there, I cannot read them. I know it's an object, but what's written over there, I cannot read it. Simple. Right? Last but not the least, anomic. Anomic. I'll repeat pure word deafness again. Don't panic. I've got some good questions with me. I'll ask you there. You'll understand them better. Anomic, anomic. In anomic aphasia, what happens with the patient is that their naming is impaired. Rest all is well. Look at this patient now. He is known as anomic aphasic patient. Anomic aphasic patient. Why? Because his naming is the only thing which is impaired. Rest all is well. So such a patient who cannot name, rest of the constituents of speech is perfectly normal, is known as the anomic patient. Anomic aphasic patient. Okay. Now, remember this. I'm using this word last but not the least because most common type of aphasia that we have with us is anomic aphasia anytime. The most common type of aphasia that we have with us is an anomic aphasia with us. Okay. And anomic aphasia is something which is typically seen in patients with Alzheimer's disease. Don't forget this term. Alzheimer's disease. Okay. It could also be seen in patients with head injury or head trauma. And even in patients with metabolic encephalopathies. Metabolic encephalopathies. So these are few conditions that they are attached with the anomic aphasic patients, that is Alzheimer, head trauma, and metabolic encephalopathies. Okay. Okay, what is the difference between anomic and circumlution? See, anomic wala cannot even tell me the real function of the object even. He might understand it, okay, it's an object, but what function? He doesn't know that. He cannot produce a real name also. Okay. So circumlution is something I always keep it separate. It does not mix with the anomic patients. Okay. So I believe this table is more than sufficient to understand this aphasic patient. Because if you read Harrison, there is a chapter on aphasia which is almost 4 or 5 pages in length. And anytime I myself read that aphasia chapter in Harrison, I myself get aphasia, global aphasia. Now some people are asking what is global. It's a very general term, global. Global means that everything is lost, comprehension, naming, repetition, and fluency. So everything goes off global aphasia if you read some books like Harrison for this topic. Just a bit of anatomy again on this topic. Right. Remember this. A bit of anatomy again into this topic, which is very, very important thing. Yeah, pure word blindness patient, is he illiterate? No. I'll give an example. For example, what's written in front of you in English, you know it. But if it is written in front of you in Chinese or Japanese, obviously you cannot know it. So I don't call you illiterate. Possibly you're not exposed to that language. So every word of that language is just an alien word for you. Okay. Metabolic encephalopathy means anything. It's a very variable thing. It can be hepatic encaph. It can be any electrolyte imbalance causing it. Okay. Okay, where is the lesion like? Okay, I'll just tell you a few facts on lesions also. People are asking me about that. In anomic aphasia, the lesion is somewhere seen in the temporal lobe. Temporal lobe. In anomic aphasia, they found the lesion was somewhere seen in the temporal lobe. Okay. Just a word about pure word blindness also. Now, there are many books which keep on changing the statement here that in pure word blindness, where is the lesion seen at? Just write this down. It is the splenium part of corpus callosum. Splenium part of the corpus callosum. In Harrison, they write it like this. Splenium part of the corpus callosum has been labeled as an area for pure word blindness. Now that's the controversy. Some people say angular gyrus. Okay, fine. One of the authors have given for anomic aphasia an area known as angular gyrus also being labeled. One of the authors for pure word blindness also they have given angular gyrus. But I'll go with Harrison on this. In pure word blindness elixia, the lesion is in the splenium part of the corpus callosum. Okay. Anomic aphasia, temporal lobe or maybe angular gyrus. See, angular gyrus is in the parietal, temporal and frontal junction actually. It's an area there. Okay. Now, bit of anatomy again on this topic, but it's something very important clinically. For example, right now, most of you are writing with your hand. Okay. Hand that you use for writing defines your handedness, right? Now, most of the people in the world are right-handed. Some of the people in the world are left-handed. I'll go with the statistics given in Genong on this, that really 93% people in the world are right-handed and 7% people in the world are left-handed, and some of them are ambidextrous is the name, I don't remember the right name. They write with both the hands, they're very intelligent people. Okay. Now what is this handedness supposed to do? This handedness, somewhere if I look at the patient with aphasia, I understand where is the speech area being located. Now, speech areas were Wernicke's and Broca's. Now, cortex or the lobe of the brain that okay, has been classified into two heads. One is a dominant hemisphere of the brain, and the second one is a non-dominant hemisphere of the brain. Now remember this, the cortex or the hemisphere that we have with us has been not not technically but rather physiologically been divided into two hemispheres, dominant and non-dominant. Now what is the meaning of the word dominant here? The dominant hemisphere of the brain is the area which contains the Wernicke's and the Broca's, while the non-dominant is the area which doesn't contain the Wernicke's and the Broca's. Now can you tell me which is a dominant lobe, left or the right lobe? This is a very simple question. Yeah, no boxes today. I obeyed your order. Yes, left. The left hemisphere in all of us is considered to be the dominant lobe, and the right hemisphere is also considered to me as a non-dominant lobe. Okay. Apart from this, someone told me a nice thing. Dominant hemisphere is also known as a categorical hemisphere. Categorical hemisphere. Non-dominant is also known to me as a different name, representative hemisphere. So there are two hemispheres of the brain that we have with us. One is a dominant, which is also known as categorical. One is a non-dominant, which is known as representative. And take it like this. You are left-handed or you are right-handed. The dominant hemisphere for all of us is always the left hemisphere. And the non-dominant hemisphere is always the right hemisphere for us. Okay. Now, there is an artery which supplies these speech areas. Okay. The supply of the speech areas, which I know, I'm talking about the blood supply, Wernicke's and the Broca's, has to come from an artery known as the middle cerebral artery, a very important part. Now, can you tell me which MC is going to supply Wernicke's and the Broca's in the brain? Of course, the left hemisphere. The left MC. Why? Because the left hemisphere contains the speech area. Okay. The area of the brain, the right one, doesn't contain the speech area. So left MCA supplies this one. Now if I can make a simple diagram of the MCA, I'm not going to the complex anatomy part. The MCA divides into two parts. One division that goes above is known to me as a superior division. One division which comes down is known as an inferior division. Remember this. So there are two divisions of the middle cerebral artery every time we get. One is a superior, other one is an inferior division of the middle cerebral artery. Correct? Now remember this. The superior division of MCA supply an area for speech, that is the Broca's area, and the inferior division supply an area for speech, that's the Wernicke's area. And again I repeat, this is nothing but your left MCA all the time. Okay. So that's about a basic patient. Now let's take out some questions and we'll get wiser on these topics by solving MCQs. Okay. Because I always feel myself that if I have an MCQ related to that topic which I've just done, I'll be able to understand the topic much better anytime. Now look at this question. Question number 1. A patient is being evaluated for aphasia, is unable to repeat sentences correctly, cannot name objects also properly. Look at this patient now. His repetition, the repetition part is lost in him. Okay. He cannot name the objects properly. His naming part is also lost. So the keywords that we have in us now, look at the keywords. The patient is unable to repeat, unable to name the objects properly. However, the patient's speech is effortless. Now look at this word, effortless. He can speak on his own a lot. If I'm speaking effortlessly, obviously the fluency of my speech is increasing. There are frequent errors in word choices and obvious difficulty in comprehension now. His comprehension is something which is lost now. Correct? Now, can you tell me, looking at this patient, which aphasic patient are we? Are we, no, no, don't answer me. Be methodical in this. Where is the lesion? Like now, it's a Wernicke's or it's a Broca's aphasia. Tell me that. Obviously, it's a Wernicke's aphasia. No doubt on this. Now, if it's a Wernicke's aphasia, the lesion has to be temporal. So when I look at the question, there are two temporal lobes, option A and option D. Which is a better answer? Obviously, option A. The dominant left hemisphere, the temporal lobe, the posterior part, having a superior temporal gyrus, is getting involved in these patients. It's a very simple answer. Okay. Now let's look at this. 75-year-old male presents with an acute stroke. He has got mild right arm and the face weak. Now look at this patient, stroke patient. He has got infarct something. His right side is weak. As you know, if there is a right-sided weakness, the lesion is always in the contralateral cortex. That is the left side. Okay, so the lesion is in the left cortex. Left cortex gives a house to the Wernicke's and Broca's. So it's a dominant categorical hemispherical lesion. Simple. Now the spontaneous speech. He has got spontaneous speech. I'm stressing on this word spontaneous speech. The word spontaneous speech means whenever I'm talking to anyone, that is my speech spontaneously. That means now what happens? His fluency is intact. That is what we have now. His fluency is normal. He can understand and follow commands. Now look at this. If he can understand and follow commands, what is normal? His comprehension is normal. While his repetition is severely impaired. Look at this now. His repetition is severely impaired. What is impaired now? The repetition part is impaired. Now, if I look at the repetition part, it is lost in this patient. And surprisingly, my examiner doesn't give me anything about the naming. It's a question mark. How's the naming of the patient? He doesn't tell me anything. Now, how to solve this question? Look at every option, you'll find the easy answer. If it's a Broca's aphasic patient, what will be lost? Fluency is lost. In my patient, the fluency is intact, so he's out of the race. Transcortical, any type of a transcortical aphasia, correct? What will happen in the patient? Repetition will always be normal in that patient, if you remember. So it is not a transcortical aphasia either. If it is an anomic aphasia, if you look at anomic aphasia, naming is lost, but remember this, in anomic aphasia, repetition is normal. So neither is it anomic, neither is it transcortical. What are we left with? Conduction. Simple answer. How did I solve this question? By rule out therapy. I kept on looking at every option and I tried to calculate the answer. My college professor used to always tell me that, beta, neurology is like maths. Then I realized my maths was poor, that's why I became a doctor. And my neuro always went poor and poor. Sad game. Okay. Another question, simple answer, clear answer, big question, easy answer. 62-year-old female presents with stroke evaluation due to acute right hemiparesis. For the last several hours, right hemiparesis is the left-sided brain lesion. She has got a right facial draw, right arm weak, mild sensory changes in the right arm, that's fine. She has got an effortful and a fragmented speech. Now look at her. Her fluency is decreased. She is unable to name several objects. Her naming is lost. Her comprehension is intact. And her repetition is lost. Now look at this patient. It's a very easy guess. It's a patient of Broca's aphasia. Some hemorrhages fugax was there. Don't panic. It's annoying. You're just blinking. Okay? All is well. All is well. All is well. All is well. Don't panic. Okay? So which aphasia are we talking about? It's a Broca's aphasia. Simple. Now, where is the lesion likely located in? Where is the lesion likely located in? It's in MCA. Which division if I'm thinking about Broca's? Yes, it's a superior division of MCA. Because the Broca's area is supplied by the middle cerebral artery on the left side and it's a superior division. This is how you approach the right answer. It's a very simple question. Good. Now this is a question which I saw last year in NEET PG and it was an easy question. and I found that every student were giving their own kind of answers. Most common deficit in a phasic patient is in question number 4. Question number 4. Most common deficit in an aphasic patient is in. Now tell me the answer. Okay, good. Naming. Naming. Yes. The reason behind this is that the most common aphasia was anomic aphasia. And the only deficit that they had was naming. So look at your examiner, how clever are they? Don't answer fluency, please. People were just calculating how many minuses on each side. It's a very simple logical question. Okay, anomic aphasia is the most common and the deficit is only in naming. So he asked the question like this. So remember, these questions also do come in NEET PG. Okay, and they behave like this. If you remember, Babaji ka Thulu. If you are very intelligent. If you are very intelligent. A person names Plentel for pencil. Now, I've given this answer. Person names Plentel for pencil. Yes, it's a paraphasia. He is telling me an incorrect word of the thing. Yes. That's known as what? Phonetically incorrect. Known as phonemic paraphasia. Phonemic paraphasia. It's a simple answer. Now, this one. Okay. A patient with aphasia has impaired comprehension for spoken words. Comprehension is lost in the patient. Impaired repetition. But a preserved naming. Oh, I just wrote N over here. I'm sorry. But a preserved naming. And a fluent speech. Lesion is likely located in which of the following site of the diagram? A, B or C? Yes. Where is it located? He cannot understand the spoken word. He cannot repeat the spoken word. He can look at the object and tell me what it is. He can speak on his own. Yes. The lesion is located here. If you remember, this was known as what? Pure word deafness. Pure word deafness. I'm deaf to words. Okay. So you might get these kinds of questions also. Don't panic. They're very easy if your concepts are clear. Now this one is a tricky one. An elderly male suffers a stroke that appears to involve the left internal capsule rather than the cerebral cortex. It results in paralysis of the right arm and the leg. The tongue deviates to the right side is lost. His speech is slurred, fluent and grammatically correct. Which of the following describes the speech deficit in this patient? Tell me please. I'll not give you any hints on this. Only hint that I can give you here is to read the keyword, the speech is slurred. But fluent. Grammatically correct. Nothing about comprehension, nothing about naming does he tell me. This patient has got a weakness in his tongue muscle. He has got a lesion in the left internal capsule due to stroke rather than the cortex now. Look at this now. Yeah, good. Some people are answering me very correctly this. It's known as a term known as difficulty in articulation of speech. Known as what? Dysarthria. Now find this out. How does it all happen? It's very simple. Like if I make this as a cortex. Sorry for the box today. Okay. I make this as a cortex. Cortex has got two areas inside it. One is for the word understanding, that is a Wernicke's. One which is for word production, that's a Broca's, and the connecting link between the two that we know as arcuate fibers. Right. Whenever I'm talking, the word is coming on to the tongue muscle and somewhere below into the pharynx, or I can put the word as larynx better. Okay. Larynx also. So every word which I'm getting in from the Broca's area is coming down onto the tongue or might come down to the larynx also. Okay. Now tongue moves and I put out the right word. When the word comes from the Broca's, comes to the tongue starts moving. If you know there's a cranial nerve which moves the cranial nerve is number 12th. That is a major supply for the tongue musculature. Okay. When I look at the larynx, there's another cranial nerve there known as the 10th, which is supposed to maintain my phonation part. Now look at this. The articulation, that is a word which I am speaking out by moving tongue up and down, is through the tongue muscle, correct? While the laryngeal muscles is for what? Phonation. So there are some phonate words with me, like doesn't come out from the tongue, it comes from the larynx. But on the other end, if I speak a word like t, this word will come when I articulate the speech with the tongue, correct? Now there is someone who is coming down with all these things. Okay, that's a very basic diagram. I'll make another one parallel to this. If I look at this as a cortex, the cranial nerves, the 10th and the 12th, if you remember, are located where? The 10th and the 12th cranial nerve are located where? They're well located in a part of the brainstem, the lowermost part, known as the medulla. Correct? Now, what happens? Whenever the signal from the 10 goes, it goes to the larynx for phonation. Whenever the signal from the 12 goes, it goes to the tongue for articulation. If you know this from the basic anatomy again, the medulla is also known as a bulb of the brain. So there is a simple tract which is connecting the cortex with the medulla below, the bulb of the brain. This tract has got a name with it as a corticobulbar tract. Now there is a tract with me known as a corticobulbar tract, which is connecting the cortex with the medulla part below, corticobulbar. Okay. Now this has to pass through the internal capsule again, because if you know the internal capsule has got fibers, I'm writing the word IC to understand the internal capsule. So there's always an internal capsule between the cortex above the medulla through which these fibers are going to pass. Now look at this now. There is a lesion in internal capsule rather than the cortex. Look at this name. The corticobulbar fibers are affected. Because of this, the tongue muscles are not getting any signal, and this patient is not able to articulate the speech well. What is this known as? Dysarthria. Correct? If the laryngeal muscles are unable to move properly, what will be known as? Difficulty in phonation, known as dysphonia. Please tell me, if there is a lesion above in the cortex, what will be that known as? That is what we read just now, aphasia. So aphasic patient, the lesion was always in the cortex. Wernicke's, Broca's, or the connecting fibers. Laryngeal, dysphonia, tongue, some spelling mistake, sorry, dysarthria. So these are few terms that you should be oriented with. Now, how will the patient present? Aphasia, I've told you a lot of things. How will a patient of dysarthria present? I'll give him tongue twisters. Like your Trivantapuram, of course, that's a perfect example for Indian population. Or maybe Irish confabi, I don't know the spelling even, Irish confabulary. Or maybe I can ask him to spell out this word, constitution. Constitution, okay. Maybe another few words which are tongue twisters, like hippopotamus and all that. So all these words which I speak, he cannot articulate them, and there is always some slurring of speech coming in. Okay. Dysphonia, yes. I asked the patient to say ah or something like this. He cannot pronounce that word properly. Aphasia, you know, a lot of things happen. Okay. So there's a few problems in the speech apparatus. It can be in the brain, it can be in the larynx, or it can happen on the tongue region. Kya kacha papad, pakka papad. No. Okay. I'll find this one out. Damage in to categorical hemisphere usually leads to. Damage to categorical hemisphere usually leads to. Now that's a very typical kind of a question that we have. In some way, the old question bank that you get in your guidebooks. Damage in the categorical hemisphere leads to. It's a very confusing one. It's very difficult to answer this question, first of all. I cannot read the mind of the examiner. Is it Wernicke's or Broca's? It's very difficult. Now, I've taken out this controversial question to remove the controversy out of it. Normal speech is not the answer, please, first of all. Now, please be careful. Don't answer it. Listen to me, please. Increased speech. That is a jargon speech that somewhere happened in patients of Wernicke's. When the Broca's area was intact, they can make words which are not connected with the Wernicke's, one thing. Then we have a decreased speech. That is a telegraphic speech in which the speech output is decreased. And then we have a senseless fluent speech. Our speech fluency is intact, but whatever he's talking senselessly. What is this? This is Wernicke's. This is also Wernicke's. And this if you keep it as Broca's. Now answer my question. Damage to categorical or dominant hemisphere usually leads to what? Very tough, very difficult. Why? Look at these terms, please. I have taken this question out because increase and decrease speech I always think as a layman term. Why? I'm talking more. Am I aphasic? No. You are talking less. Are you aphasic? No. What is more scientific term? I'm asking you again, please. Don't equate these B and C as Wernicke's and Broca's. There are some layman terms that I get. See, option C is not written as telegraphic speech. It's just written as decreased speech. I'm talking that day less. I'm having decreased speech. Is it aphasia? No. So what are we left with? What is more scientific a term, please? A senseless fluent speech, in which he speaks with a normal fluency but he talks senselessly. Whatever comes to his mind, he keeps on talking like that. Okay? So I agree, it's a very controversial question. It has come at least 4 times in AIMS PG. I saw this. Controversy gets repeated in AIMS only. That's why the problem there. So remember, one answer I'll always be confident about is D, because B and C are some options which I think as a layman term. D is a better answer anytime. Now a big question but an easy answer. Big question. Now, let me read that question first. A 78-year-old man has a cardiac arrest while being treated in an emergency room for chest pain. The resuscitation was initiated immediately, but a profound hypotension was observed for at least 20 minutes time. Cardiac rhythm restored, but the patient remained unconscious for the next 3 days. When he was awake, alert, extubated out, the speech was limited to repetition of words and sounds around him. He had no apparent comprehension. He produces few words spontaneously. Whenever the patient is spoken, he is fairly repeating what is said to him. Yes, some people are answering me correctly now. This is what my patient I saw was a patient of what? Echolalia. Correct? Now if it was an echolalic disorder, what disease am I expecting it to be perfectly? Yes, it was a mixed transcortical disorder. Alexia. Correct? Can you tell me why not is it posterior transcortical aphasia? Why not this? Because in them also repetition is normal. Posterior was Wernicke's, in which the fluency was intact or might have increased also. So it is not that. Okay. So this one is an easy one. Patient is having impaired comprehension only for reading, but a normal comprehension for a spoken language. Okay, patient has got impaired comprehension for only reading, but normal comprehension for a spoken language. Repetition of spoken words and fluency is normal. What are we talking about? Yes, the answer is nothing but pure alexia. He can repeat, he can speak, but whatever written in front of him, he cannot tell me that. It's known as pure alexia. Okay. If I take out one more topic, actually, I'll eat away some 25 minutes of yours. Okay, and I think so. I'll take cryptococcal meningitis and channelopathies, if at all, in the subsequent classes. Don't worry, I'm not running anywhere. Okay, so there is an abrupt end to the class today. इतनी खुशी आज तक नहीं हुई. Okay, don't worry. Aphasia is over with you, which is the topic for the day. Uh, I'll see what all topics I can take. Okay, in due course of time, because I've got at least 3 to 4 days leverage with me, right? So I know you're really tired. If I take another topic out like cryptococcal meningitis or channelopathies, you'll never understand it because you yourself are having global aphasia at this moment. Okay, any doubts? Uh, Post them on Facebook Club. Okay, 2020 Facebook Club dams which we have. Okay, so you can post there. Don't post them individually under my post. Under my post, and today I've made a lot of memes. Please go back into the Facebook 2020 Club and see all those memes. You'll really understand the topic much better. Okay. See, I cannot take any more topic because it is going to eat away some 20-25 minutes. Unnecessarily burdening you when I have got a leverage which can take in some other day. It's fine. Okay. Yeah, I'll cover maximum, nothing minimum. Till date, I was always taking 20-25 minutes extra. Okay. Okay. Good night. Stay home, stay safe.